We're going to be talking today about Seeking Safety, a therapy for trauma, post-traumatic stress disorder, and substance abuse. I began developing this model in the early 1990s. At that point, there hadn't been a model yet developed that addressed the issue of trauma in the context of substance abuse. We're going to talk about three main topics. First of all, background. What do we know about the connection between trauma, post-traumatic stress, and substance abuse? Rates, gender differences, clinical presentation, and most of all, what is the experience like for these clients? Also, treatment. We're going to talk about Seeking Safety in particular as a model that attempts to address trauma at the same time as the substance abuse. What's sometimes called integrated treatment, in contrast to older models that were called sequential treatment, the idea that first you treat the drug addiction or substance abuse, and then, and only then, do you go on and treat the trauma or PTSD. And that had been the word in the field for a very long time. And I think at this point, what the field is getting to is the consensus that integrated treatment in general appears to work well for a lot of dual diagnoses, whether depression and substance abuse, borderline personality disorder and substance abuse, and PTSD and substance abuse.
And the problem is that in the past, if we send them to just substance abuse treatment and they stop using substances, their PTSD symptoms go up. And then in the past, for just treatment of PTSD, we tell them they have to be sober for a long period of time before they can receive treatment. And that's particularly difficult for these veterans.
We're also going to look at outcome studies about how clients may change if they're given focused treatment on this connection. First, probably highly familiar to people here, but what I'd like to do is start out right out of the DSM-4 with the definition of PTSD. And many people use the word trauma loosely to mean any difficult event in life. But technically, in the DSM-4, a trauma involves the experience, threat, or witnessing of some sort of physical harm. It might be child abuse, for example, physical abuse or sexual abuse, domestic violence, assault, severe car accident, life-threatening illness, natural disaster like hurricane or tornado, combat experience, and it evoked intense fear, helplessness, or horror. The person was overwhelmed emotionally when the trauma occurred.
When I was selling cocaine, my house got robbed. They kicked in the door, hit me in the head with a sawed-off shotgun in the back of my head. That's all I remember. I woke up in the hospital with a contusion. From there, I got stabbed several times in my back. I just really traumatic. I was devastated.
And remarkably enough, most people who go through traumas do not go on to develop PTSD. The rate is actually 1/3. Still a very important and substantial percentage of people, but nonetheless, 2/3 of people who experience trauma do not go on to develop PTSD. When someone does develop it, it's 3 core sets of symptoms. And it's worth memorizing if you haven't already, because clients often don't know that that's what they're experiencing. And they sometimes feel as though no one quite understands, or they shouldn't reveal how bad they feel inside. So just giving language to their experience. Intrusion, avoidance, and arousal. Intrusion being the person keeps re-experiencing the event over and over in their mind, not wanting to. It keeps coming back in flashbacks and nightmares, intrusive thoughts, and so on.
I knew there was something wrong with me because I get flashbacks. While I'm sleeping, I used to beat up my partner. Like, I'll dream about things that I've been through, and I'm back in one of my rapes, and I'll start fighting, and last thing I know, I wake up and my partner will be full of bruises, and I didn't know that I was doing these things.
Avoidance, often called the hallmark of PTSD, because when someone meets the criterion for avoidance, they tend to also meet the other criteria as well. They don't want to talk about the event. They feel very upset by it, but they can't go near it. And arousal, feeling intensely triggered both physically and emotionally when reminded of the event. Hypervigilance, startle reflex, insomnia, intense anger, and so on.
Sometimes I wake up at night streaming. You know, I had some of my roommates to tell me that sometimes I wake up, I'll stream out, you know, and it's from that, the stress, you know, that I went through.
And it endures more than a month. If it's less than a month, it's known as acute stress disorder. But for most people, within 1 month and even up to 3 months, many people will resolve the symptoms. So this is for the people where it endures over a longer period of time. And I'm sure what you've seen in treatment programs are people who have suffered with this disorder for even decades, many, many years, often without it being identified. One of the really unfortunate public health issues at this point is that only 4% of people with PTSD get accurate diagnosis of it, and even fewer get directed treatment toward helping them with it. So still a major issue in the field, both in the mental health and in substance abuse programs, to help these clients identify it and hopefully heal from it.
I had a therapist who I think was just simply not understanding. You know, my first therapist told me that I was suffering from an identity crisis. Despite the fact that I really outlaid, you know, not just the sexual abuses, but several other issues from my childhood.
And it causes some sort of functional problems. The person will say, I don't feel the same as before the event. I feel damaged. I can't focus at work. I can't concentrate. I can't relate to people in the same way. If the trauma in particular was interpersonal in nature, they may feel betrayed. They may feel that they can't trust anymore. They can't reach out or connect with others. And a quote from William Faulkner, the American writer, who said, "The past isn't dead. It isn't even past." And when you think of the nature of trauma for many people, the past lives on until there's some help for these clients to address what happened to them. 2 precepts from H. Wesley Clark, the director of the Center for Substance Abuse Treatment in Washington, D.C. First of all, the idea, no wrong door. It's very important to treat trauma in substance abuse settings, and likewise to attend to and address in some way substance abuse, no matter how the person enters the system. And for a long time, systems have been split. A client would be rejected from substance abuse treatment for being too symptomatic in mental health symptoms, too suicidal, too depressed, too upset, behavior that was out of control. Or the opposite, the client was using, and so the idea in mental health might be, first let them get the addiction dealt with, but we can't take them in while they're still using substances. At this point, a growing recognition in the field is that for many clients, unless they get integrated treatment, no matter how they enter the system, they may not get the help that they need. A second principle, don't ask and they won't tell, that for many clients there's such shame and guilt and hiding of what they lived through. There may have been no one to tell in the past when they went through the traumatic event, or they might have been punished for telling. And so the idea is actively screen for trauma, really help the client identify it, and make assessments systematic and routine for clients so that it's not just when you suspect something may be occurring or may have happened in the past, but making sure to address trauma and substance abuse with all clients, hopefully using validated instruments, of which there really are a number at this point. Even brief self-report screening tools that are done in a systematic way can be very helpful in frontline programs. Also, not a term used in the DSM-IV, but one widely used in the field is the concept of complex PTSD, that particularly for people who underwent trauma at young ages, who went through repetitive trauma, who went through trauma by perpetrators who were in the family, who they were supposed to trust, that there may be much more damage to the personality and to a whole variety of symptoms beyond just the DSM-4 symptoms. Things like self-harm, cutting, burning, self-mutilation, suicidal attempts, and so on. Relationship problems such as distrust, not being able to connect with anyone, or the opposite, connecting in ways that are too close and unhealthy, that don't work for them, such as domestic violence. They keep staying in the relationship even though they keep being hurt, unsafe sex, and so on.
I guess I could start with growing up with my father, who was an alcoholic, and he was abusive to my mother, to the children. And he died when I was 11. And then I got involved with a man when I was 14, and he abused me for 13 years. We managed to have 4 children in that time. And he would wake me up strangling me, he would beat me, he would pretty much do anything he could ever, rape me, he would do anything imaginable.
Boundary problems. The person doesn't know how to set limits with other people in their lives. Sexual problems, paranoia, a sense of distrust toward other people, brief psychotic symptoms, not directly schizophrenia or other psychotic disorders, but just short flashes of either delusions or hallucinations even, where the content often is trauma-related, hearing a voice telling them that they're bad, seeing a shadow and being very scared of it, thinking it's something threatening to them.
I started talking to myself, which was something I never done before. And I don't know, I felt like crazy.
Somatic symptoms, the concept that the body remembers, that for some people they express emotional pain in physical ways, and so particularly in children or adolescents, and certainly some adults as well, you see the physical expression in nausea, other kinds of physical problems. Dissociation, the tendency of the client to unwittingly often remove themselves psychologically from the present environment. Sometimes they're triggered by something connected to the trauma. They'll describe it as spacing out. Their eyes may look glazed over. They may look like they're no longer with you. But it's a very common symptom for people who've experienced severe trauma. And one of the things we'll be talking about is how to bring the client back, how to help the client reconnect with the present. Reenactments, the tendency to repeat in behavior what they haven't yet processed or fully dealt with emotionally. So cycles of bad relationships, cycles of continually getting into struggles or fights with people, inability to get along, inability to sustain gains, and so on. And finally, loss of sense of self, sometimes feeling fragmented, feeling empty, feeling split in some way. And a quote from David Kaloff, who said, "They constantly tell their stories, sometimes with words." The idea that for a lot of these clients, they will repeat in behavior a lot of their traumatic experience until it's addressed, named, and worked with. Also, community-based epidemiology studies have looked at the co-occurrence between PTSD and substance use disorder. A major study was Kessler in 1995, who found very high rates of co-occurrence. Among men with PTSD, 52% develop alcohol use disorder in their lifetime, and 35% develop drug use disorder. Among women, the rates are 28% and 27% respectively. So very high association between the two. And in treatment settings, you actually see much higher rates. For example, in substance abuse treatment programs, 30 to 59% of women have current PTSD, and 55 to 99% of them have experienced at least one and often more lifetime traumas.
I just think it's very important to realize the connection between people that have experienced trauma and are diagnosed with PTSD and how addiction plays a role with that. Because for years I didn't know about that connection. And now that it makes really a lot of sense to me, knowing that with the flashbacks and nightmares, the hypervigilance I have, the startle response, that is PTSD, and then along with my history of addiction, it helps me take it off more of a moral stance, so that I understand that I'm not a terrible person, which is what I thought for years. I have a terrible disease. I am an alcoholic and an addict. I have a history of trauma, PTSD, and a history of depression. And so I'm beginning to understand now why I have such a long history of addiction, and how I've used addiction to treat the trauma.
And a very clear and consistent finding that those who experience both disorders tend to have worse outcomes than those with either disorder alone. In a series of studies by Dr. Paige Ouimet, those with PTSD and substance abuse improved less, had worse coping, more distress, and more positive use of substances than those with substance abuse alone. And often a feeling of being crazy, lazy, or bad, an internalized sense that somehow they have failed, that something is terribly wrong with them, that people won't understand, that people will think that they're sick or damaged in some way, and often hiding some of those internal experiences.
One of the really positive things I think that comes from the treatment is it gives clients a chance to make the connection between PTSD and their substance abuse, and more importantly, I think, to identify that some of the things that they experience are PTSD, to have a name for what their experiences are. I've had women say that, it's almost oh, so this is why I feel the way I feel, or so this is why this happens to me, or so this is why I think this way or act this way, because they've had this perception that there's just something wrong with them as a person, that they have some sort of horrible defect, or that that they're just plain crazy for some of the things that some of the experiences that they have. So to have a name to attach to it is often a very positive experience.
Unfortunately, sometimes in families and even in treatment programs, they may get messages that reinforce that. Just get over it, move along already. That event happened 20, 30 years ago. You should just focus on the sobriety and so on. You're defocusing if you attend to the trauma. And a little more about PTSD and substance abuse, and then we'll go on and talk about treatment. For most clients, for 2/3, the PTSD occurs first and then the substance abuse develops, fitting what we often think of as a self-medication that the clients may be using as a way to escape emotional pain, as a way to numb out.
I think with trauma, you look for escapes. You look for, because if you're constantly thinking about or in the middle of what it is that you've experienced that's really horrific, then you would have no peace at all. And so one of the ways of trying to distract from remembering different things is to do things that I like, or things that will numb you to the effects of how the trauma has manifested itself in your life.
It certainly goes in the other direction as well, that clients who abuse substances are at higher risk for traumatic events and thus the development of PTSD. The lifestyle of addiction, spending time with dangerous people, dangerous situations, crime associated with drug use and so on may lead people to more traumatic events. And certainly for some people, they grew up with both, sometimes in the family very early on. One of the major predictors of who develops both of these disorders is family history. And unfortunately, there's the repeated cycle over generations of these illnesses, particularly when people go untreated.
I grew up in an alcoholic home, and my dad was an alcoholic, and he was, my house was pretty crazy. He also, I'm convinced, suffered from PTSD from the war. He was in World War II, and there was a lot of tension always in the house, and it would occasionally explode into craziness. You know, I can remember many times as a little kid being, you know, frozen in fear. I thought it was normal. You know, I ended up being a very, very withdrawn kid. You know, very shy, and you know, basically, I wasn't very good socially at all. You know, I had no social skills whatsoever until they poured a drink into me.
Two key themes in treatment: control and secrecy. When you think of the very nature of PTSD, no one ever asks for a traumatic event to occur. It's always unwanted and uncontrollable. When you think of substance abuse, by definition, it means the person has lost control over their use. And so what you often see in these clients are struggles around control, difficulty taking control of their lives. They'll often say, life just happens to me. I don't plan, I don't direct things, I don't try to actively cope. Or the opposite, sometimes over-controlling, getting into struggles, not being able to work with others and adapt to rules. And so in treatment, one key goal is empowerment, helping the client take control in healthy ways. Another theme is secrecy. Really, more than a lot of other Axis 1 disorders, both PTSD and substance abuse are beset by hiding, lying, minimization, guilt, and shame. No one they could tell about the traumatic event, wanting to hide the substance use, certainly even from themselves. And so there too, in treatment, one of the goals is to help the client learn how and when to open up and to be honest. When is it safe to do that? But the idea that with someone at some point they need to be able to be honest about both. There's no particular drug of choice for the dual diagnosis, but the use of hard drugs is common, meaning cocaine and opiates. Also, misuse of prescription medications is very common. PTSD is classified as an anxiety disorder in the DSM-IV, and so what you often see is an attempt to reduce anxiety by use of substances.
I drank to relieve the pain. You know, I was a very confused kid. You know, I had all these feelings, low self-esteem, you know, fear, anxiety, and you know, the alcohol lessened the anxiety. You know, I was always anxious. I was never able to relax.
PTSD does not go away with abstinence and may get worse in many cases. This is different from some other dual diagnoses. For example, major depression, generalized anxiety, typically tend to get better the longer the client maintains abstinence from substances. With PTSD, one often has to help the client prepare that they may worsen in trauma-related symptoms. They may get flooded with the overwhelming memory and emotion that they've been pushing away with the substance abuse. Also, people can recover from PTSD. One of clients' most urgent and deep questions is, will I ever get better? And one thing we know about PTSD is that in some cases, full recovery is possible. Typically, if they suffered one event in adulthood, it's more likely that they'll have full recovery, in contrast to people with what we termed earlier complex PTSD, repetitive events, childhood-based, often within the family. But nonetheless, for all clients with PTSD, whatever type of origin it was, clients can recover to the point of no longer meeting criteria for the diagnosis. They can live a functional life, and basically they can move on and move forward. And it's up to them ultimately to determine how full that recovery is. Many people will say they never feel that their lives will ever be the same given what happened to them, but nonetheless, they can go on.
I feel very grateful that I've been able to identify my history. Because I could never understand what was wrong with me. And now that I've been able to identify it, I can move on. I don't feel like my feet are stuck anymore. And I don't look at it as painful. I mean, I look at the pain as being difficult, but I also look at it as being a way that I can move on. I feel very optimistic. and I'm a survivor. And I can say I'm going forward.
Why are clients using? One hears a lot of different meanings for drug use in the context of PTSD. I use drugs to access feelings or memories. I feel numb, I feel detached, I feel dead. And using just helps me to feel something, feel alive. Drugs to shut off feelings or memories. I'm overwhelmed, I can't cope, I can't get through the day. And so using just helps me to relax, to calm down.
I liked the marijuana because it was calming to me. I could still function, and I smoked, that's what I did for a long time, and then I went to the alcohol because it just went away. It was different. It was like all the pain went away. I didn't care. He'd beat me, I'd get drunk and wake up in the morning and forget about it. It didn't matter. I felt comfortable in my own skin, I guess. I liked it. I liked being able to pass out. I liked being able to go to sleep and just forget it all.
I've learned through years of counseling and searching for an answer that I drank because two reasons. I needed to feel or I needed to not feel.
Drugs as revenge against an abuser. This was my only way to control my body when something was happening to me. Drugs as slow suicide. I want to die anyway. And so whether it's drug use or something else, I don't really care. And in fact, among people with PTSD, not even taking into account the substance abuse, 19% will attempt suicide at some point in their lifetime. And so very important to attend to suicidality, to those wishes to escape through death. Drugs as learned behavior. This is how I learned to cope growing up. This is what we did in my family. We drank, we used a substance. And very important to give clients a lot of reassurance about PTSD. It's okay to be in pain. Often just the permission to know that they're upset is okay, that they can experience that. People do recover, that in fact some people will have complete remission, complete absence of symptoms, no longer meet criteria for the disorder. You're not crazy, it's a normal reaction to abnormal events. That was a definition used in the original diagnosis of PTSD in 1980. Eventually, epidemiology data showed that in fact, trauma is in fact very common. In the US population, about 60% of men and about 50% of women experience at least one trauma in their lifetime. And so it's really not an abnormal event. Nonetheless, it's a great phrase to use with clients, and it can help them feel validated, feel normalized. And finally, it's not your fault. And a lot of these messages will take a lot of repetition. It's certainly easy to say it's not one's fault.